So welcome everyone to this webinar, and this webinar is focused mostly on diagnostics in rural and remote, and we are going to discuss various aspects related to diagnostics regarding its access, its usability, and various other aspects related to diagnostics. Especially the context will be rural, and it will be much more focused on LMICs, that's what's possible in our area, and we'll discuss on various other aspects related to diagnostics. Focus is mostly on diagnostics in rural and remote, but we are going to dedicate our most of the time on discussing some aspects which are more relevant to LMICs. We can discuss all the global issues also. So I'll start with a round of introduction from you all. And I'm Dr. Pratyush Kumar, Chair-elect for Rural Wonka and Chair of Wonka Rural South Asia and the convener of this Global Rural Health Summit. And I would like to welcome you all to the summit, third webinar on diagnostics in rural and remote. Next is Christos. Introduction, please.
Feel privileged, Dr. Kumar. Many thanks. I had the pleasure in serving many years ago the Wonka Working Party on rural health, and now I'm chairing the Wonka Working Party on mental health. Thank you very much. I'm medical faculty, University of Crete, Greece. Thank you.
Thank you. Thank you. Omnia El-Sharif.
Hello, everyone. This is Dr. Omnia El-Sharif. I'm a family medicine consultant in Cairo University Hospitals, and it's been my pleasure to join the work with South Asia and at the same time to participate in many events.
Okay. Thank you. Victor? Victor Inem? Shuma Resh?
Hello.
Yeah.
Sorry.
Please.
Yeah, I'm Suma Rache. I'm in my final year of PhD. I'm looking at the remote and rural medical educational aspects with Professor Kathy Jackson.
Okay. Where are you working currently?
I'm in UK doing my studentship.
Okay. Thank you. Thank you. Marilena?
Hello, this is Marilena Anastasanki. I am a public health and epidemiology researcher at the School of Medicine of the University of Crete. And it's really nice to be here with you. Thank you.
Thank you. Gobit?
Yeah, good afternoon, good evening, good morning. Yeah, this is Gobit from Sri Lanka. I'm a rural family physician and executive rural Wonka and portfolio for the LMIC. Great to be here.
Thank you. Thank you. Rupesh Madisetti?
Good evening, sir.
Good evening.
I am a third year postgraduate at NRA Medical College in Andhra Pradesh.
Okay. Welcome. And next, Dr. Yusuf Al-Tahu.
Yes, hello. How are you?
Hello.
Hi, lovely seeing you. So my name is Dr. Yusuf Al-Tahu. I'm the Kingdom of Bahrain representative of Young Family Doctors under a Razi group, which is following Wonka EMR, as well as the Royal College of Surgeons in Ireland graduate. Lovely meeting you all. Thank you.
Dr. Bernadette?
Sorry?
Thank you.
Thank you.
Yeah. Dr. Bernadette? Can you hear me? Yeah.
Okay. Hello?
Yeah, please, sir.
Oh, sorry, I am somewhere I cannot put on the camera. I was not allowed to. So I am based in Germany and I run a medical device company in Cameroon and with a community community rural health entrepreneurship. That is why the rural health with a rural health center. And so I am happy to be here and I'm happy to share the exchange and experiences. My main focus is how do we get the diagnostic into the remote areas in a cheap and a feasible manner and more practical things. Yeah. So it will be nice to have the exchange with you guys. Yeah. Thank you.
Thank you. Vasu?
Hi, thanks Pratyush and thanks everyone. I'm Vasundhara. I'm a lab medicine person. I'm a general practitioner and a public health person in parts of rural central India.
Thank you.
Thank you.
Nishchay? Nishchay, can you hear us? Marjorie Cross, can you hear us?
Yes, I'm present.
Yeah, please tell. Can you please introduce yourself?
Yeah, I'm Dr. Nusra. I'm working as a medical officer in Hassan district.
Okay, welcome. Defrike, nice to see you after a long time.
Hello, Pratyush.
Yeah.
How are you?
Good, good. Can you please introduce yourself to everyone?
Yes. Yes, my name is Ndifreke Udonwa, Professor of Family Medicine. Yeah. I teach family medicine in Calabar, University of Calabar, and I also practice family medicine in the University of Calabar Teaching Hospital. I'm in Nigeria, a fellow of the 2 colleges in Nigeria, a long-standing member of Rural Wonka. Thank you. Good to see you.
Thank you. Thank you. Ezaz Khan? Ezaz Khan, can you hear us? No. Okay. We have any other members who would like to introduce themselves? I would be glad if they can open their camera. Yeah. Thank you. Thank you. Kathy Jackson?
Hi, I'm Kathy. I am in the UK. I work at the University of Central Lancashire, where we also have the National Centre for Remote Rural Medicine in England.
Okay. Welcome. Paula?
Hello, everyone. I'm Paula Torres-Fleming. I'm an MD epidemiologist, and I work with indigenous communities in the Amazon of Peru.
Okay. Dr. Ezaz Khan? You can unmute yourself. Yeah.
Yeah, sorry, you were calling. I was just away. I'm Ijaz Khan. I'm professor of public health at Health Service Academy in Pakistan. Thank you.
Thank you. Welcome. Welcome. Dr. Vandana Bubna, can you hear us? Dr. Vandana? Okay. Oleksi, can you hear us? Yeah, you're.
Yes,
thank you.
Now. Good afternoon for everyone. My name is Alexei Korsh. I am head of Department of General Practice Family Medicine at Kharkiv National Medical University in Ukraine. A member of Wonka.
Thank you. Welcome. Welcome. And anyone else, you can just switch on your video camera and I'll invite you to introduce yourself. I will begin with the main webinar. And first, I'd like to welcome Vasundhara, who basically, it was her idea to have this as a sub-theme of this summit. And I'd like her to just begin this, open the discussion regarding the webinar on diagnostics in rural and remote, and then we'll take your opinions regarding the diagnostics, which modalities you use in your practice, what's its implications, how you benefit it with the people, and what's the volume with which those modalities are being used, and how far those are effective, cost effectiveness, everything we'll discuss in this webinar. So Vasundhara, it's over to you.
Yeah, thanks Pratyush. So the reason for introducing or not leaving behind diagnostics, which is usually the case, we talk about clinical, we talk about a little bit about nursing, but I think lab diagnostics is left out, or it is trivialized to point of care tests like 1 drop of blood or something like that, not looking beyond that much. These ideas stem from the places I work at in rural, remote, central India, where I really cannot trivialize lab medicine. And it's not just upper respiratory infections or diarrheas that show up. In fact, rural and remote areas get affected by one of the most complex infectious diseases. And the next level of care can be 100 kilometers or 50 to 60 miles or 200 kilometers. So we need to have a robust care system right there where the clinic is. And a simple RDT for malaria or scrub or dengue, it doesn't do everything, doesn't solve everything. For almost 25 years, although I spent a good deal of time in the US, I used to come back and I saw the same thing. So wherever there was good lab practices and good array of lab tests available, the data is also better. The disease burden data is definitely better in places which have a good lab beyond RDTs. And the kind of tests that are offered in places where I work at, I've shared it in the group as well. Yes, there are RDTs for malaria, dengue, scrub, hepatitis A and B and HIV, VDRL or syphilis, but training technicians in microscopy, which often gets, again, within the lab itself, microscopy gets pushed away because it's a scary thing to learn, is the perception I get always. But in a country, again, it is very context specific, so people are free to tell about their place, but it has certainly helped pick up a TB in a faster way, because while we talk about Gene Expert, while we talk about TrueNat, which is homegrown molecular test, it is still 100 kilometers away for a lot of people. So if one knows ZN staining, we pick up a lot of cases much before the sample goes to, sensitivity can be an issue, but even for those we pick up, they save a lot of money in transport, save a lot of time going to a place which offers molecular test. And if it's a private place that's offering molecular test, it's even more expensive. Then even peripheral smear for say malaria, or even to confirm the diagnosis of anemia, kind of, so that has helped. Then fungal lesions, again, we can talk about sensitivity at a later date, but leprosy, in the past 1 month, my lab technicians have picked up 4 cases of leprosy by doing the slit skin smear. So I'm just talking of one aspect, which is the microscopy part, but we need to bring back or bring in complex tests, or not really complex. Be courageous enough to accept that even these tests are required at a primary care level in remote areas, because the diseases are also complex. Either that, and then for culture, because again, we don't have data for any blood culture or pus culture or urine culture from remote and rural areas. So while it may not be feasible to start culture facilities in such places because it's a lot of investment, why don't we think of a hub and spoke model where a tertiary care center, a government center, or I'm not a big fan of PPP model, but yes, the bigger places should, they should be incubating, or they should be extending services to the remote and rural places for culture, especially for culture and molecular tests, so that transport system, establishing the transport system. So that, and then third is the kind of technicians I get again in this part of India. are people with degrees, but they wouldn't have seen a microscope. They know how to do a finger prick for random blood sugar. They may or may not have pricked for drawing blood. They do not know about the 4 or 5 tubes of collection. So the education system is also that bad. So a lot of training from scratch goes on when they join. And within a year or two, I've seen that they become so marketable because they know so much. And almost everyone who leaves or is lured by either the private or government places because they know a lot more at the end of 1 year with good teaching. So it does take some hand holding. It does take some frustrating training, but the output and the outcome have been fantastic. Yeah, so I think, and patients go back with same day results in remote and rural, and that should be the aim, because in rural and remote places, people cannot keep on coming back to take the results on the next day. And the diagnosis and treatment is given on the same day based on these lab reports. When I'm not there, the follow-up happens. A lot of them have started taking pictures of, say, microscopy or even peripheral smear or some biochemistry thing or quality control online. However, that is not, teleconsultation is not the replacement for in-person training. So yeah, a couple of points I just highlighted over here, which were also mentioned in, or probably left out in the position paper points.
Okay. So if I'll
Yeah.
summarize these things, there comes 5 important subheadings. First is the health workforce, the main workforce who can do the diagnostics. Second is the planning of resources, like availability of those kits, the smear, microscopes, slides, vacutainers, and all the things. Third thing is the training, that training of the workforce, the adequate training so that they can do the purpose which they are meant to be done. And fourth is the quality checks, not only for the lab reports, but also for the workforce. And the most important thing is the access and availability of services. So these are the 5 subheadings which I feel is most important in the field of diagnostics. And we'll explore to these things with all the available panelists and guests who are available in this webinar. I'll go to Christoph and I'll just ask you that what's happening and what's your experience with the diagnostics in your area. What's the availability in your area and how does it work in your settings? Christos, can you hear us?
Yes, I'm thinking that's more important in listening other colleagues, and certainly that will be wonderful for me. I think that is one of the challenging issue at the moment, and then needed to be adapted in the local and the regional conditions. I think that variety and variation among the practices across world is very important. Of course, we're talking about elements, but I think that very important also in take into consideration the diagnostic capacity of healthcare providers, and it's not only a technical issue, it's also a complex issue that's needed more consideration of the complexity of healthcare systems, needed more training capacity and capability and skills of healthcare providers, but also I'm thinking that is also our understanding and our evidence based from the island of Crete, also relevant to patients' perception, expectation, and wishes. I suppose that there's so many colleagues could just contribute to that, and also on behalf of Crete, Dr. Anna Sasaki will, of course, will give in a further feedback. Thank you very much.
Yes, thank you, Professor Leonis. In In summary, diagnostics are not largely available in rural settings of Greece and in rural practices and healthcare centers. And that has been a discussion for many, many years now. I recall, Professor Leonis, the discussion we had the other day about your experience with diagnostics when you were a practitioner at a rural healthcare center in Crete. It is a discussion for that. Some services are scarcely available. Okay, apart from some basic diagnostics for respiratory infections, let's say for COVID, for flu. Other than that, there's nothing continuously available. There are some services like diagnostics regarding pap test, pap smear test for provided from, let's say, for selected healthcare centers who are active, let's say, on this perspective. But in principle, there is no specific plan for enabling diagnostics in rural practices and rural healthcare centers in Greece. So that's a big gap, because we have a large community, a large rural community. And at the moment, there is not sufficient will to equip rural facilities with specific diagnostics. So this paper and this collaborative act is very important, will also give a very important message for Greece as well, okay? I
Thank
hope
you.
I conveyed the situation as much as I could. So yeah, thank you.
Okay, thank you. And if anyone else, Victor Inem would like to, Nifrike would like to discuss something regarding this, you can unmute yourself.
Okay, thank you very much, everybody, for this very, very, very important discussion. I must thank my colleague for quickly remembering that we need to discuss this rural diagnostics. And from first-hand experience, I know very well that for the quality of care and training and research, we need to collaborate. So what I did in my first-hand experience was to highlight the importance of the hub and spoke method. I really had to collaborate with those that work in the laboratories and solicited their ideas on how to make sure that I function very well in the rural area in the midst of poor infrastructure. And they gave me brilliant ideas, which I used, and they worked very well. Otherwise, the quality of care may be compromised and may not be considered to be the optimum by your other colleagues. They may think that you are doing substandard practice. Second was the manpower, like Pratyush has already talked about. The manpower definitely was not available. And therefore, you have to look for any way that you can use the available manpower in the urban or suburban areas. And you know that manpower and quality go together. If you don't use good manpower, you have poor quality service. And therefore, what I did was now to begin to change the mindset of my other colleagues in family medicine and rural care, that we need to do good quality practice in the rural areas. Therefore, we need to put in as much as we can to make sure we raise the quality of services there. Definitely, the facilities are not as available as it should be to support the services, but we have to do some kind of, we have to think out issues that surround the care of the rural person. Finally, I consider this discussion very extremely important, because the way they take rural practice, especially in our area, is that somebody might say, after all, they are doing it in the rural area, therefore you don't need to give the same importance like it would be given in an urban area. And it is for us to now highlight what we are highlighting now, and probably come up with a paper or with a position that will emphasize the importance of diagnostics in the rural area, using the available services and also the manpower that might be available, even from other faculties. Thank you very much.
Thank you. So can you please tell me briefly that what are the tests available in your center, like in the primary care setup in your country, the common basic tests which are available, and is it free for all in the government setup, or do they have to pay some money to access those tests?
Definitely the basic services that are available are the usual basic primary services like the blood sugar, hemoglobin, and the rest of them. There are facilities to do those ones. But when you want to go beyond that primary care diagnosis, you now have to look for a way to sustain that diagnosis using a higher center. And that means transportation of the specimen and the manpower. That means even funding might be involved. So those are the basics. The services are available because manpower is now forced to go into the rural area and then serve. But now, if you don't have the facility to do the test in the rural area, you have to either transport yourself and the facility transport yourself and the specimen, or look for a way of preserving the specimen so as to be able to transport it to the urban or suburban area. And the patients, they pay for themselves, sometimes out of pocket. Sometimes government gives a little support for a diagnosis. But those are what is, we have all those services available, but we also have individuals that are not willingly available to serve in the rural areas. Therefore, you have to design a way to make sure that you move those specimens to where you can do the diagnosis and then also offer your service.
Okay. Okay. Thank you. Thank you.
Thank you. Yeah.
If anyone would like to speak, they can just raise their hand through the options they are given in the Zoom account. They can just raise their hand and I'll just point it to you. Next, I'll ask Victor in him because his video is on, so I can see him. That if you can describe the situation in his place regarding the diagnostic services and.
Thank you very much, Dr. Kumar. I'm extremely privileged to be amongst you this morning. I have retired from practice, so I was more in a listening mode, but I'm back into training my medical students on rural and remote health. My experience has been that we have all been left behind the matter of diagnostics in the rural areas. Nobody in the government, the private sector, nobody really wants to invest in this. The most we have is to have the basic diagnostics, like rapid malaria tests and things like that, and hemoglobin and blood sugar. And that's where it ends. But using even Lugol iodine for pap smear is seen as going into the past. So what we have to do is to make all of us be aware that there's a continuum between the past and the present. And what we were using, those tests that we are using in the past are still possible in the rural areas in the present. So I will suggest to this webinar that yes, in this age of RI and AI, a lot should be done to get us in the rural areas to connect with modern diagnostics. It's very, very important, and I think we should give it very serious thoughts. Well, like the lady in India was speaking about leprosy, all these neglected diseases are still endemic in the rural area. Unfortunately, the diagnostics, even the modern diagnostics, have not caught up with many of these neglected diseases of leprosy, onchocerciasis, leishmaniasis, and things like that. So we have to encourage the private sector to invest in making more of these diagnostics, more of the modern diagnostics available to rural practice. And it will help a lot to make us better practitioners. Thank you.
Thank you. And you have raised a very important issue here, that what we call as the conventional test or the traditional test are getting obsolete with the emergence of rapid diagnostic kits, which gives reports within few minutes. But it has also shown that there is lack of training. People are not being trained in medical colleges for these tests, which are called conventional or traditional tests. And in the area of need, where there is the issue of access and the issue of low resources there these tests can fill in those gaps. And I believe, what are the issues which you see that why the new medical students and the new training of medical students, why we are not teaching and why we are not focusing on the old traditional test? Is it because of lack of sensitivity or because of quick results?
Well, first of all, the issue of quick results. We live in an age in where everything we need is instant coffee, instant beverage. So we really, the expectation of the modern medical students is that whatever you do should give instant results. And I agree with them, because we cannot live in the past. We should look for ways of getting some of these instant results available to them. And you find that most of the resource we had, human resource we had in that area, they are in their 70s like me. They are not in tandem with what is happening in the present. So I think we should move with the present, move along with the present times, and find ways of filling the gap of many of these diagnostics that are not available for rural practice.
Okay. I'd like to invite Gobit from Sri Lanka. He would like to discuss something regarding that. Gobit?
Yeah, I can share my experience. Actually, Sri Lanka is a small island country with over 80% are living in rural. So in the case, almost all the people have accessing the rural healthcare facilities. With that one, also, we also having same kind of this low resource, like including the trained medical staff, health staff and all. So for particularly in my area practice like that, so we didn't have the proper investigation or laboratory services. But later on, what we did it, we have done a trained staff, actually not through this university and all, actually with some A-levels pass community workers trained by through the national system. Actually, they are not get the diploma. They have placed with the part of the payment through the public partnership, and also we got a semi-analyzer at at that time. So actually, previously we only have maybe, as you said, we can do the blood sugar. Like that's only we have the practice test. Then after gradually introduced, as you said, like we have the tropical country and we have the dengue and other things. Especially we have the very bad dengue season was there. So we need a frequent full blood count and all. So with this hemolytic analyzer, so we are able to do at least dropping off with this platelets and WBC and all. So in the background, actually we have had a small initiative from the ministry. Actually, this is one of the pilot project to those few districts. We have the cluster system. I normally used to talk about even the other way. Even part of the cluster system, they introduced the laboratory services also. So it is reached to the one of the apex center, maybe secondary or tertiary care hospital. So we may collect, especially about the long-term medical condition, diabetic hypertensive patient. We used to have this all like maybe renal function, maybe the lipid profile, and all for at least for 6 month time. So what we do is we collect the date, we give the date, and we arrange the transport to deliver to the sample there. So then they are sent all these reports through the some other way, secure way to the us. So at least they will get. Actually, the frankly say, so most of our long-term conditions, so who are following the NCD clinics, patients all have done a basic screen about even when they come for the diabetic, they have the fasting blood sugar, at least the serum creatine, maybe lipid profile. That things we have arranged for the even for the last 2 years. So that's one of the great thing I see, because nowadays we have the more patients are with the people with the NCDs. Also, like I said about that rapid test, you are talk about that. Even during the dengue season, we had a dengue kits, NS1 antigen kits. Actually, it need a serum, but even with the you can done with the blood drop as well. So maybe not 100% accurate, but if we see within 24 hours, you may had. Actually, we got a earlier we got a bigger price, but anyway, I don't know. So maybe we got some maybe stock from the sinus something. So we got a very cheaper brand as well. Not cheap means it's a standard one. So we able to identify even within 24 hours before dropping the even counts about the dengue patient. So that's why we can do even about the to stationary is the at least so some kind of laboratory system. Maybe we are connected with the other secondary tertiary care. So that be one of the answer to maybe at the moment we catering to the laboratory services. Thank you.
Okay, and my question to you is that like, is all the tests available for free of cost to all the patient, and is it available at primary healthcare level?
Yes, actually everything is free. Sri Lanka, the full whole health is free. Almost all tests we can do with. So only thing is HbA1c we have a limited one, because even though secondary hospital has limited one, so we only limitedly we do. But anyway, even fasting blood sugar, serum creatine, lipid profile, everything free for them. Even then to come for the even for the repeat review for the patients. At least we do. At least creatine we do every 6 months. Even maybe lipid profile for this for the who are having on the drugs, so they will get at least 3 months. All are free.
Okay, thank you, Dr. Bernadette.
Okay, yes, thanks for the opportunity to share my observations once more. So what I can say, especially for the rural community in Cameroon, is cost is a problem, because not many people pay out of their pocket, and except they have screening campaigns. So somebody wrote, I'm sure Vasu wrote in the forum, if we recognize the fact that during the COVID activities run down deep into the rural communities. So it is possible, where there is a will, there is a way. So if we move along the 4 pillars of one financing, because I started behind with financing, because most of the issue is financing, who finances what. And being somebody as an entrepreneur who is active within the rural community, I realized that yes, the NGOs, they assist to do a good work. But at the end of the day, you cannot build any health system based on NGO actions. So somehow identifying that problematic of financing and trying to see how can we make the health system an economic factor also in the rural community, it will be helpful. And two, Dr. Victor said we should move into the modern. Yes, moving into the modern means first of all identifying the traditional diagnostic methodologies that can be useful, that are cost effective, that are preservable within the rural setup. Because if we do not stay within the context of the rural setup, we might be talking things that are more for the urban, for the cities, but the rural setup means how I remember the books in those days of where there is no doctor, where people could read and see what simple medications or what simple first aid they can do within their communities. In that same light, there should be a guideline book for laboratory technology and diagnostic with the simple and the traditional methodology for the rural communities. Yes, let us hope that with the industrialization and maybe with more miniaturized diagnostic kits, machines, if they're small enough that can be easily transported to the rural community, then we can say using the modern and the AI system will have compact machines that somebody can put in the handbag and do rural campaigns. But the center is without diagnosis. Many people spend, and one of the saddest thing is some people travel 2 hours to go get blood sugar, blood pressure checked, and some of the secondary health centers are over full with people that do not actually needed to travel that journey if they had the simple laboratory or the basic traditional laboratory at place. One thing I realized also in Cameroon is the paradox of healthcare workers. You have in the cities, people are trained, people pay a lot of money out of pocket for those nursing or health science trainings, but like Dr. Vasu said, some of those trainings for the certificates are not practicable because there are certain simple things, methods that should be in the handbag of any person that is within the working the health field. And the third thing is, how do we get the workforce? They're using the same pathway of the community health workers. We can identify and train people within the communities to work with the health specialists and make these things possible. So I lay my case for now. Thanks.
And it reminds me of this inverse care law of Julian Tudor Hart, which we quote multiple times, that where is the greatest need for healthcare, no, they tend to receive the least access to quality care services. And that's most quoted quote of Julian Tudor Hart. And I believe that's very much applicable in our situation also. And I'd like to discuss something more regarding what do you feel is lacking in rural area? What are the gaps in diagnostic services which you feel that with help of training the resources, train the health workforce, and getting the resources, we can fill those gaps? Like, may I invite Dr. Varsha Sridhar? Can you hear us?
Hi. Yes, my network is a little poor. Can you hear me?
Yeah, we can hear you.
Can you just repeat what you said just before you asked?
We discussed regarding this, the diagnostics in rural and remote areas, and we're talking about the gaps and what are the ways which we can fill those gaps in rural and remote areas regarding the resources, the workforce, the training, access, availability of all those things. So what are the common gaps which you see, and what are the ways to fill those gaps?
Sure. I think in terms of the gaps, a lot of the earlier speakers had mentioned this, including Dr. Udonwa and Dr. Inem, with regards to like staffing. And I think Dr. Inem had also talked about the lack of specific kind of tools which are sort of future ready. I do want to add, I think I had already talked about this in the WhatsApp group. Let me get rid of my video. But I'll put it over here anyway for other people's feedback as well. I do think we should go beyond just looking at these building blocks. The WHO has given these 5 or 6 things saying, okay, you need the tools, you need the people, you need money, and you need this and that. That is great. And I absolutely believe that those are critical attributes for us to have. And as everybody has said, but in addition to that, does that mean that once you have the tests in hand and you have the trained people in hand, you are somehow going to be able to solve the problem of a patient coming to, say, a sub-center with something a little more complicated than just an anemia or something like that? I don't think that's enough, right? Like, you need to have enough communication processes within your referral systems. You need to have there's a mentality of patient centricity, and there's a mentality of accountability. I think many of those are attitudinal attributes which we tend to forget. And so in addition to the building blocks, I would like to suggest that this sort of training of a sort of flatter hierarchy, where it's not just the doctor on top and everybody else sort of underneath this one chief, but it's more of a teamwork. That attitude, I think, should be brought in. The second thing I'm realizing as I hear other speakers, including the speaker from Sri Lanka, is that a lot of primary healthcare or rural healthcare does seem to be government sort of driven. And over here, again, I want to bring up this thing about how does the government decide what tools to get and how much to get, and what is the procurement process? At least in India, from what I understand, the procurement process is, I think, a black box, which is sort of shrouded in some degree of mystery. You know, there is a tender that goes out, and it goes out to a bunch of different, vendors. But who decides what is the specific product that ultimately gets bought? What digital hemoglobinometer gets purchased? What glucometer gets purchased? If you ask the PHC, nurses or technicians in many parts of India, you will see that many of them will say, we don't actually believe the HB results from these hemoglobinometers. I would much rather look at somebody's eyes or somebody's nails and then say, yeah, you probably have anemia, because the hemoglobinometer is going to give me something like 16 or 17 for a teenage girl, which I know that can't be right. So, that kind of stuff. So I would like to put this across as well as to how do we choose what actually gets purchased. Thank you very much.
Thank you. Thank you. I'd like to open this discussion to other participants who would like to contribute. I'll just pick out names. If they can hear me, they can just respond. Elizabeth Verghese, can you hear us?
Yes.
Yeah. Can you please share your thoughts on this topic on diagnostics in rural and remote? What's your experience regarding this?
Actually, I have worked in a rural area. Presently, I'm not working in a rural area. I worked in a rural area in Tamil Nadu, India, many years back. But that was a secondary level hospital with, but it's a small town, but it catered to the villages around, and it had a good equipment, fairly good lab, and there was not much problem regarding the there was not much problem regarding catering to the needs of the patients as far as diagnosis was concerned. It catered mostly to the poor, and I'm basically a general practitioner, and I haven't I'm not knowledgeable enough to comment on I don't have the experience like the people like you around here to comment on this setting up of labs in rural area and all. I have joined here out of interest, actually.
Thank you.
So
Thank you.
thank you for giving me the opportunity.
Thank you. And can you hear from other people what their thoughts on this? Izaz Khan? T-Dose? Like anyone? Fatima Najafipur? Can you hear us? Poonam Sharma? Divanto Andoko? Kathy Jackson? Anyone? Yeah. Kathy Jackson, you can just share your views on this diagnostics.
Hi, I'm very much of the opinion that near-patient diagnostics make a big difference, particularly in remote and rural areas, or they have the potential to, certainly in reducing expense and reducing overall expense, much as we've already heard. I'm keen, as I've just put in the chat, to learn from the experience of others, particularly those working in remote and rural areas, if they've come across issues with calibration and maintenance of any of the technologies that are used for near patient diagnostics, because that, to me, it's using near patient diagnostics is not difficult. There's obviously training required for whoever's using them, particularly not everybody who uses them is going to be a doctor. So there are, other professions that use these technologies. And I'm just wondering if anyone has come across any issues with calibration and maintenance, and if so, how they have managed to overcome these potential problems. So just throwing it open to everybody.
Varsha Sridhar? Yeah, please.
Hi, I can share my experience with with two of them, with a hemoglobinometer and a glucometer, both in rural settings. We used to use a HemaQ before, and we realized that it actually getting, yes, it requires calibration, it requires maintenance, and getting this in our settings was quite difficult. Then we actually went through a number of Indian or rather local manufacturers of the same devices, did a comparison study of all these devices after getting, informed consent from the patients, and picked one that actually had indigenous both supply as well as maintenance. So this worked out really well because we had access to these manufacturers, to at least like 4 or 5 manufacturers, and we could reach out to them and say, listen, we are here. Do you think you can, enable proper maintenance and supplies and things like that? And that's one of the reasons why it was successful. I look forward to hearing other people's comments as well.
Anyone else have to say on this topic on calibration? Christos, yeah, please go ahead.
I enjoy very much listening a fantastic discussion. I know, and also notified that certain colleagues already have captured the subject and integrate the old traditional patterns with the modern technology. I think that is a key issue at the moment. Depends on the available laboratory capacity. In certain times, technology, despite that having an enormous benefit, is not available in many settings. That we needed to just discussing diagnostics very related to the available technology, and also seen it to other available technology could just reduce the cost and also just facilitate performance and diagnostic in family medicine. I'm remembering one serving an isolated area many years ago when just I'm accountable performing general blood account and general analysis of urine. I'm not just strongly suggesting now in utilizing traditional and old-fashioned technology, but sometimes in some areas potentially that's old laboratory technology potentially could be useful. I think that we needed in preparing different models and different scenario, and also just it is very important in seeing technology to what extent the technology and diagnostic are serving the population have problems. For instance, at the moment in Greece, Dr. Anastasaki know very well, working together. We have one of the major problems in primary care in general in rural and urban areas is antimicrobial resistance. And we need that is a particular problem from some areas in Europe. We needed to just exploring available diagnostic into consideration of for the population health problems, and also just needed to look upon any training programs that are available. To what extent the training programs are effective in changing the performance and the skills, and also cost-related analysis and cost-benefit and cost efficiency analysis needed to support to what extent diagnostics are serving also that dimension. Thank you very much.
Thank you. Vasu, please go ahead.
Yeah, thanks. Unless someone else also wants to speak, I'll say later. Okay.
Like if anyone have
Um,
anything to speak, they can just raise their hands and I'll just invite them to talk.
Okay. So when I wrote about the title, like local with global implications, this is exactly what was there in my mind, that the data from rural remote is so poor, especially regarding antimicrobial resistance. And with so much travel happening, we don't know which bug is traveling where. Yeah, we don't know the local susceptibility pattern. We don't know the local um, microbial profile, but there is so much mobility of people. You know, the borders are so porous. So that also is a reason why we need whichever way to have a local data. We follow CLSI guidelines, we follow UCAST, but we really don't know what's happening every year or what the trend is in local spots. So yeah, that's why it is so important to know, have
Yes.
regional, sub-regional data. Yeah.
Thank you. So I think we have come to the end of this webinar. It's already 1 hour for this webinar. I'll just take few final comments on this thing. And I'd like to summarize this with that. We overall, the diagnostics in rural and remote areas is one of the most important thing. If we have got very good primary health care, then the load, what we are discussing, the load on secondary and tertiary will decrease by many folds. If the morbidity is less at the primary care levels, then obviously the need for tertiary care will reduce. And for the diagnostic purposes, to make a diagnosis, obviously clinical judgment is vital, but we need to have a proper diagnostic to have a confirmed diagnostic, because we also want to get away from misdiagnosis and also from overdiagnosis. Both kills people. And I'll take the final comments from you all. Victor, your comments on this? Yeah. Can you please unmute yourself?
Thank you. All right. Thank you. Like I said earlier, we people who practice in the rural areas, we must try as much as possible to come in tandem with with modern practices. Therefore, we should encourage the industrial complexes to bring simple tests. So I would suggest that from this webinar, we should look at a list of at least 10 common tests that will be needed in any rural community. Irrespective of where you are in the world, at least you can bring out 10 diagnostics tests that are prevalent and will be of use in your environment. If we can do that, that will be a beginning to cutting down costs, to making sure that the human resource backs what we are doing. Thank you.
Thank you. Thank you. I think we can include this in our position paper to have the basic minimum tests which should be there. I think it may vary from place to place, because in my state, Leishmaniasis is common. Some places, Onchocerciasis gas is common. Some places, fibrosis is common. So it may vary, but context specific, we can have at least these are the 10 basic tests which should be there available at most of the primary healthcare centers. Thank you. Anyone else would like to give their final words? Nifrike, Paula Torres.
Yes, hello.
Anyone? Yeah.
It has been very interesting to know the experiences around Asia. Just a brief summary here in the Amazon. I've worked with very remote areas, but also I'm working here with peri-urban areas. And it's amazing how the primary care health system doesn't get into them. So basically, once you go and visit these communities, you only have just a clinical interview, no point of access of diagnosis and everything. And sometimes they rely with one visit to the communities per year, because the health post where there's a technician, it's usually closed, no? So that's a hard thing to deal with. Yeah.
Thank you. Poonam Sharma? Okay. So anyone else would like to speak anything? We are going to end this webinar. And thank you. Thank you all for this very engaging webinar. We have got understood lots of things regarding diagnostics from your viewpoint, and we understand various gaps which are available. And it would help us to prepare our position paper on diagnostics in a better way. And thank you all for joining this webinar. Our next webinar will intimate you very soon on the mail and the WhatsApp group. Thank you. Have a good day.
Thank you very much, Pratyush. Thank
Thank
you.
you.
Thank
Good
you.
day.
Thank you, everybody.
Thank you, everybody.
Thank you.
Thank you.
Thanks, Pratyush.
Thanks. Bye-bye. Take care.
Bye.
Bye.
Bye. Thank you.
Okay.